Bienvenidos a una nueva conversación titulada KINETALKS junto a Joe Nijs y estoy aquí con hartos colegas también de diferentes partes que están apoyando la iniciativa desde tempranito. Vamos a aprovechar a hacer algunas preguntas relacionadas a su investigación, conocimiento y algunos consejos para la práctica y los clínicos y también quizás respecto a su investigación. Así que espero que aprovechen la instancia. And first of all, thank you, Joe, for your time. You're very kind. It's the second time that we've been doing this live. So, first things first, would you mind to introduce yourself a little bit for the ones that are watching you now?
I'm a full professor at the University of Brussels in Belgium. I'm a visiting professor at the University of Gothenburg in Sweden. And I'm also a part-time clinician as a physiotherapist, manual therapist.
Yo, para presentarse brevemente, le pedí que dijera algunas palabritas y además de ser profesor de la universidad en Bélgica, también tiene un cargo en Gotemburgo y además es clínico part-time. And now I have a few questions for you now. Well, first, I would like to know if you have any advice for the ones that are just starting to learn about chronic pain. If you have a favorite or top three papers that you would like to recommend, or maybe a book as well, what would you say to them?
Well, if you just start off studying chronic pain, then I would recommend that you dig into the modern pain science for sure, that you try to understand what pain is and especially what pain not is, so that you dig into in the understanding of pain, because of course, especially in the last few decades, there has been a massive change in our understanding of pain and chronic pain in particular. So that's important, of course, as a starting clinician, that you have a thorough understanding about it. But besides that, my second main advice would be to dig into the four key pillars of health in general, and that's of course stress, physical activity, lifestyle, and diet. Those four key pillars of health for every human being on this planet, no matter whether they are suffering from chronic pain or whatever kind of illness they're faced with, or whether they are in good shape. That's always appropriate for any human being, and more work is now pointing in that direction, that this applies also to people with chronic pain. So to become a good clinician for dealing with chronic pain, I would advise anyone to dig into those four pillars of health and make sure that you're able to support your patients if one or more of those pillars are actually not functioning or doing it as they supposed to be doing it. For instance, if we know that 1 out of 2 patients with chronic pain have a severe sleep problem, then for sure you need to be able to support them in returning to a good night of sleep. And the same with diet, the same with stress intolerance, and physical activity, of course, is our core business.
Amazing. I'm going to translate that now.
Okay, yes, sorry, I probably need to shorten what I'm saying to allow you to translate it.
It's okay, don't worry. Joe dice que primero le aconsejaría a las personas que están empezando en este camino del entendimiento del dolor que traten de comprender realmente lo que es el dolor y además de eso que idealmente también entiendan lo que no es, porque ha habido un gran avance en la última década en particular de los estudios y del conocimiento y de cómo abordar a las personas con dolor persistente. Así que después de eso dice que una de las cosas fundamentales que ha cambiado el paradigma en los últimos años, que todo clínico debe abordar, los pilares del estilo de vida relacionados a la actividad física, el estrés, la higiene del sueño y la alimentación, y que nosotros podemos hacer un cambio, aunque quizá lo más relevante o probablemente lo que más vamos a poder interferir va a ser la actividad física. Hay un montón de herramientas que podemos también utilizar para tratar de influenciar esas otras dimensiones que son sumamente importantes, que una de cada dos personas que tiene dolor persistente prácticamente va a tener un problema en algunos de estos dominios y que podemos tratar de intervenir. Excellent. And I have another question now, Joe, for you. Thank you. What would you consider the most significant advancement in our understanding in central sensitization or nociplastic pain in the latest years?
Well, perhaps the links that also are becoming increasingly apparent, that central sensitization has close connections to the four pillars that I was mentioning. That each of those four pillars, each of those main lifestyle factors, closely link to central sensitization, implying that the poorer you sleep, the less sleep you get on a night, the higher the sensitivity of the central nervous system. That applies to people with chronic pain, obviously, but also applies to anyone not suffering from a pain condition. So the sensitivity of the central nervous system instantaneously increases on the day after a poor night of sleep. So both are closely connected to one another. There is more data coming out suggesting that this also applies to the quality of your diet. So the poorer the quality of your diet, the more pro-inflammatory your diet is, because it's more resembling the classical Western diet, the higher the sensitivity of the central nervous system appears to be. And again, we hope to be able to turn that around, and that to show also in the future that if patients start to improve the quality of their diet, switch to a more healthier diet, which is also typically a more anti-inflammatory diet, then of course the sensitivity of the central nervous system hopefully gets better. And again, I can make similar stories about the close connections between stress on the one hand and central sensitization on the other hand, but also regarding physical activity.
Yo le hice la pregunta respecto a cuál cree él que han sido los últimos avances respecto a la sensibilización central que deberíamos tratar de interpretar o utilizar nosotros en clínica. Y yo responde que sabemos que hay unos vínculos muy cercanos respecto a la higiene del sueño, la cantidad de horas y la calidad del dormir, y de cómo eso afecta o va a interferir en el fondo en el nivel de sensibilidad que presenta el sistema nervioso central, así como también con la alimentación. Mientras más occidental sea tu dieta y probablemente tenga más alimentos que se consideren proinflamatorios, ultraprocesados y de ese estilo, es más probable que el sistema nervioso también esté más alerta y podría contar una historia similar respecto a lo que pasa con la actividad física. And this one, I would say that is a tricky one, or maybe a doubt of a lot of clinicians. Esta es una pregunta quizás capciosa o quizás algo difícil de procesar para muchos clínicos. But what would you say that is the main difference between nociplastic pain and central sensitization? ¿Cuál es la diferencia entre dolor nociplástico y sensibilización central? Que esto quizás puede ser algo confuso para muchos clínicos.
Yeah, it's a good one, because it's clearly confusing many people. And that's also why back then, when we were proposing 10 years ago, the first classification criteria for what we called back then central sensitization type of pain, were in favor of sticking to that name. But the International Association for the Study of Pain took another route, not so much in terms of pain phenotyping, because the pain phenotyping criteria for nociplastic pain obviously are very much in line with what we proposed back then in 2014. But yeah, they chose to another name because they were afraid that a group of people who fall within the category of what we now call nociplastic pain is actually is actually received a name that is representing an underlying mechanism, physiological or pathophysiological mechanism. So that sets the scene for the response to my question. Central sensitization is one of the main underlying mechanisms of nociplastic pain, and nociplastic pain is now what the international community uses as the label to label those people who fall within that category and who cannot fit within the other two categories, which are nociceptive and neuropathic pain. Does
La
that make
pregunta,
sense?
yeah, it does. And well, I may add a few examples of patients maybe to understand it better, but we can talk after my translation, please.
Sure.
Y le estaba diciendo que esto, como puede ser confuso, quisiera una clarificación y quizás lo vamos a poder procesar después cuando hablemos de algún tipo de paciente como a modo de ejemplo, pero yo estuve metido en las definiciones y los conocimientos iniciales de la sensibilización central por ahí por el año 2010 y hasta el 2014 hay un montón de papers que él estaba liderando donde hablan de cómo categorizar o subcategorizar a la gente que pudiese tener un mecanismo predominante de este tipo, pero después la IASP actualizó la terminología y ahora en el fondo está orientado más a tratar de fenotipificar cuál es el tipo de predominio de dolor que tienen nuestros pacientes y la sensibilización central puede ser uno de los mecanismos neurofisiológicos que explica mejor el por qué la gente tiene dolor nociplástico, pero que lo primero es estar seguro de que ese paciente que tiene dolor nociplástico en el fondo no entra en las otras dos categorías, no tiene dolor nociceptivo, no tiene dolor neuropático, y eso es lo que queda, pero no es lo único que podría estar sucediendo neurofisiológicamente hablando. Okay, now maybe an example. I'm used to give some examples, and maybe you can correct me this time, Joe.
Sure.
For example, a person that has a tension type headache, where you are listening, obviously, and trying to pay attention to all the details, but you might do an exam, a physical exam then, and the aggravating factors and easing factors doesn't seem mechanical, for example, or it does not follow a dermatomic pattern. So you're trying to rule out something neuropathic in the half of the brain or neuro. I would say that it would be ruling out a cervical headache. And then you assess the neck and the head and everything, and the pain is not reproducing. So it might be reproducing when that person has stress or lack of sleep or other stimulus. Would you categorize that person as a person with nociplastic pain?
Well, according to the information that you have now shared with me, it sounds as if this is most likely a patient that can be categorized within the group of nociplastic pain. Yeah, I agree. Of course, I cannot say this for certain because, of course, for that I would need to see the patients, to assess the patient myself. And in general, the pain phenotyping criteria are shouldn't be regarded as strict diagnostic criteria. I think they're more like a framework that can support our clinical reasoning to be applied in clinical practice. I think it's very challenging to, if not impossible, to make clear-cut diagnostic criteria for each of the pain phenotypes. And the same is true for many of the diagnostic criteria for many of the diseases which are out there. Often it's when you look at the diagnostic criteria for osteoarthritis, rheumatoid arthritis, multiple sclerosis, you name it, they're all not clear cut. This is not rocket science in neither of those disorders. So it's often there is a gray area, and the same accounts for pain phenotyping. So regard pain phenotyping more as something that can support your clinical reasoning process and not as a clear cut rocket science thing, because that's not its intention, and it's too ambitious to say that this will ever be possible to develop such a clear-cut criteria.
So it's not black or white.
Yeah, exactly.
estaba comentándole yo un ejemplo para que él me corrigiera, en el fondo de que yo suelo utilizar un ejemplo en mis contenidos, en mis clases, respecto a que una persona con dolor nociplástico primero sería una en la que has tratado de descartar ya que existe una fuente de dolor nociceptivo y que como eso no siempre es sencillo, que el ejemplo que yo suelo entregar para que sea más categórico es una persona con dolor de cabeza de tipo tensional que entonces estás examinando, estás escuchando, estás prestando atención, te das cuenta que quizá el panorama no tiende a ser una característica mecánica, no te está contando que es el movimiento el que es problemático y tú lo examinas y le tocas el cuello y la cara y la cabeza y no se reproduce el síntoma, tampoco tiene una relación, digamos, que con una sola parte del cráneo como para pensar que es una cefalea de tipo cervicogénica, y entonces estás prácticamente descartando el cuello. Me dice que le faltaría quizá un poquito más de información, pero pareciera ser que sí, pero que tenga en cuenta que evidentemente esto de fenotipificar a los pacientes está utilizado como una herramienta para darle soporte al clínico para la toma de decisiones, para que podamos intervenir mejor, explicar mejor, que no es blanco y negro, que como en muchas de las etiquetas diagnósticas de nuestros pacientes, por ejemplo, si tú piensas en un paciente con artritis reumatoidea, con artrosis de cualquier tipo en la extremidad inferior, con esclerosis múltiple, los diagnósticos no siempre son blanco y negro. Hay muchas veces que van a haber similitudes entre pacientes que se cumplen, pero hay muchas otras cosas que también son individuales. And maybe if I have to add another detail for that case scenario, I would say do you still use the central sensitization inventory?
I still use it as a standard tool that patients complete when they see our clinic. So the first time before I see them in the clinic, they complete a series of 5 questionnaires that we send them through email, and we ask them kindly to complete them. And one of them is actually the central sensitization inventory. I'm not using it as a diagnostic tool, though. It's more to get a broader impression of the variety of non-musculoskeletal symptoms that they might be experiencing.
And if I may ask, which ones are the other fours, the other four questionnaires that you use?
Yeah, well, it includes also the pain drawing to get a nice idea about where the patients are experiencing pain. Then there's also the perceived injustice questionnaire, which is a one-page questionnaire to get an idea where their perceived injustice is actually part of their illness perceptions that the patient is experiencing. Then there's the pain catastrophizing scale, which also a one-page questionnaire, which generates 3 very useful subscale scores, including rumination about pain, helplessness about pain, and magnification about pain. And then there is this one-page questionnaire that we have taken from the acceptance and commitment therapy. And I'm searching for the exact name of the questionnaire, but the good thing about that one is it generates 2 subscale scores, one focusing on pain coping behavior in general, so not really focused on physical activity only, but pain coping strategy in general, and then the other one, which is focusing on the idea that patients cognitive fusion, which is patients losing their own identity and replacing their own identity by becoming a patient suffering from headache or low back pain or whatever the patient is faced with.
Let me translate that. Estaba preguntándole yo si a este dato adicional le agregase yo que el inventario de sensibilización central tiene un puntaje elevado y para que desarrollemos un poquito más esta idea del paciente con dolor nociplástico, pero está comentando que es un cuestionario que él sigue utilizando, que se utiliza como parte de los formularios de ingreso cuando él evalúa a un paciente y que son 5 cuestionarios. Yo aproveché obviamente de preguntarle cuáles son entonces los otros, porque yo estoy haciendo muchas veces investigación, entonces tiene unas formas de evaluar de ingreso que son estandarizadas y utiliza el inventario de sensibilización central, el diagrama del dolor, el cuestionario de injusticia percibida, la escala de catastrofización y una quinta escala que no recuerdo el nombre ahora, pero que tiene que ver o que se robaron un poquitito de la Escuela de Psicología de Aceptación y Compromiso, donde se evalúa el afrontamiento de la persona y cuánto del dolor se ha vuelto parte de la identidad de la persona. Después vamos a buscar el nombre y se lo voy a pedir para compartirlo, no hay problema. So, in this example, with the guy or lady with, I would say, headache, tension type headache, if the CSI or the inventory has a elevated number and the comorbidities are present, so hypersensitivity to the lights or maybe odors, then your suspicion might rise. In terms of nociplastic pain?
Yes, true. But of course, the main thing is the differential diagnosis with a possible nociceptive type of pain and the differential diagnosis with neuropathic pain, as you already explained in the beginning when you presented the case very briefly to me. In general, I also like the example of headache because it's a bit under-recognized in the field of chronic pain, these type of patients, even though the number of patients faced with chronic headaches is really rising spectacularly, and it's become one of the main group of patients, especially also in physiotherapy practice. So that's why it's important to emphasize. And the example of tension type headache clearly should alert any clinician that there is a close link to stress, obviously, because that's even emphasized in the name. And on top of that, make sure that you always screen for those 4 pillars of health that I was mentioning in the beginning. So screen for the 4 main lifestyle factors. Also, for instance, in migraine, the number 1 type of headache on this planet, there is a clear role to play in many, if not the large majority of patients with chronic migraine for sleep problems, for instance. Insomnia is peaking among patients with chronic migraine, and there are a couple of small proof of concept studies available suggesting that providing them with sleep training, effective sleep training, is actually a strategy that can benefit many patients with chronic migraine, and that's possibly also applicable to the other types of headaches, such as tension type headache.
Entonces, para condimentar un poquito más este ejemplo del escenario clínico, le estaba diciendo que si el inventario de
No, es
sensibilización fuese un
una,
puntaje muy elevado,
es
y
una
si
chapa.
además de eso tuviésemos, por ejemplo, en las características de
Bueno,
los factores agravantes y
el
atenuantes,
gallo que escapa.
que la persona tenga, sorry, my mic was open, la persona tenga como agravante o como descripción de las cosas que le hacen empeorar, que por ejemplo tenga hipersensibilidad a los olores, que tenga hipersensibilidad también a la luz, que esas cosas ya agregarían condimentos, pero dice que una de las cosas fundamentales antes de los cuestionarios nada más tiene que ser la forma de descartar o acercarnos a descartar que tenga una fuente nociceptiva, que tenga una fuente de dolor neuropático, y que hoy día el ejemplo de la cefalea a él también le gusta mucho porque son muchas personas las que padecen de este problema y que lamentablemente son infratratadas, como que solamente las tratan a través de los fármacos, y los terapeutas físicos tenemos mucho que hacer ahora también. Well, in Chile, Joe, we are not physios of direct access, so unfortunately, patients with headaches don't come to the physio. Like, well, I have some patients, obviously, because they have chronic pain, but the headache is like, it's something they have, but not the thing that they are consulting me for. And
Okay.
they get very impressed when I am talking about these pillars and pain science education. And sometimes we can make a difference in that matter because they only have treatments with medication.
Yeah.
It sucks.
Yeah, true. Well, it's a bit similar in Belgium, not totally similar. We don't have direct access either. Because in the Netherlands and the UK, it's available direct access, but in Belgium, it's not available yet, even though our professional association for physiotherapists is pushing it fantastically. So hopefully it will become available soon in our country, because obviously it can save a lot of money for the healthcare system too, and it benefits patients. But in terms of the headache patients, also being stuck within the neurology clinics, if I can call it that way, that's also partly applicable for the Belgium situation. And when we talk to neurologists about this problem, they also acknowledge the fact that they need better treatments, and that the drug treatments are slowly improving the situation for some of the headache patients. But in general, that it's clear that a multimodal approach is necessary also for these patients, and that they require a lot of better and more lifestyle focused treatments, and that physiotherapists can play a crucial role in that. So hopefully some of the people having crucial positions in your professional association for physiotherapy in Chile can become aware of this or are aware of this and can push this also within your healthcare system.
Yeah, we're trying to push forward. Well, I'm going to translate that a bit also. Yo le estoy comentando que acá en Chile no somos de acceso directo y Joe también me está clarificando que en Bélgica tampoco lo son. Bueno, allá en los Países Bajos, en Reino Unido sí son y él sabe y todo el mundo ya sabe que podemos ahorrarle una gran cantidad de dinero y de tiempo al sistema de salud y finalmente con el propósito de ayudar a los pacientes. Así que hay que empujar en esa dirección, hay que tener gente que esté capacitada para demostrar y ojalá presentar investigación y avances respecto a lo que podemos nosotros conseguir con los pacientes para que se pueda de cierta forma alejar uno del sobrediagnóstico o el sobretratamiento. Yo le estoy comentando que las personas con dolor de cabeza quizás a mí no vienen a consultar por el dolor de cabeza solamente, pero son pacientes que si han padecido dolor crónico, el dolor de cabeza es como si fuese una comorbilidad, entonces en realidad empiezo a hablarles yo de la educación en neurociencia, de los pilares del estilo de vida, de cómo lo que ellos piensan, creen, las situaciones de la vida influyen en todo esto y empezamos a generar un cambio en el motivo de consulta y casi que secundariamente eso igual influencia el dolor de cabeza. Así que me dice que allá pasa parecido, como que los kinesiólogos que están trabajando en una clínica como de neurología, los neurólogos son quienes más ven a estos pacientes, entonces probablemente desde ahí tiene que venir la derivación inicial, pero hay muchas cosas que se puede hacer para ayudar a estos pacientes también. Excellent, Joe. Thank you. And I have another question. And if you have a patient that doesn't have a diagnosis, so maybe we can imagine the direct access situation, and you are assessing the patient, and maybe she has allodynia, uh, a lot of spreading pain in the pain diagram, clearly insomnia, a lot of comorbidities. You maybe are not even able to touch her or to ask her to move. Would you say that in those cases, or also in which cases would you recommend the visit to the physician for some pain medication, for example?
Well, I wouldn't specifically recommend to see a physician for getting medication prescribed, but I would, in those situations, those very severe cases that you are prescribing that resemble fibromyalgia, chronic fatigue syndrome like cases, I would surely recommend them to visit a physician. In my experience, those type of patients typically see several physicians to get a clear diagnosis and to exclude other possible illness, and they wouldn't be coming directly to see a physio before seeing a medical doctor. But if they do, for sure, I would recommend them to see a physician. Again, not so much to get a drug prescription, but more to exclude other medical illnesses before we can assess them and explore whether they require multimodal treatment within a physiotherapy context. Since you mentioned the medication aspect, the new Belgium guideline for the treatment of chronic pain became available just before Christmas. And that clearly emphasizes that there is no such thing as an effective drug for treating chronic pain in general, and that all trials up to now were rather unsuccessful, all drug trials, that is for treating chronic pain. So drug treatment, medication in general, cannot be the first line treatment. If a clinician with a certain patient considers prescribing drugs, then it can only be an added treatment on top of a multimodal treatment approach that includes pain education, a lifestyle management, etc. So it cannot be the core business, and it cannot be a single mode treatment for people with chronic pain, because that would be not evidence-based.
Y yo le estaba preguntando ahora, siguiendo con este ejemplo del paciente más complejo de presentación en la que, por ejemplo, tienes una persona que quizás no ha pasado por el doctor, aunque probablemente en nuestro sistema de salud ya pasó por el doctor, que no la puedes tocar, tiene dolor multisitio, no se atreve a moverse, el dolor es muy intenso, hay insomnio de por medio. Si es que en esos casos consideraría la visita a un doctor o la referiría, dice que en realidad Si la refiere o si le gustaría referir a alguien, sería para investigar más, como pensando en la cabeza del clínico de que queremos excluir una bandera roja o una patología siniestra. Eso sería lo primero. Pero que la última guía clínica que salió en Bélgica el año pasado, cerca de Navidad, enfatiza que los medicamentos no pueden ser nunca el único tratamiento que recibe este tipo de paciente. Así que si se va a utilizar o se llega a utilizar algo así, va a ser solamente un adjunto en base a estos otros tipos de intervención que sabemos que sí tienen recomendaciones y que si solamente se está medicando a un paciente, finalmente ese no va a ser un tratamiento basado en evidencia. And is that guideline that you mentioned available in English, Joe?
I know it's available in Dutch and French. I need to check whether it's also available in English. For sure, we will do this. So keep posted on our Pain in Motion social media because, of course, I was also together with Wouter Munneke, the two of us, we were part of the group together with colleagues from Leuven University, Bart Morlion, for instance, a medical doctor who used to be the past president, who's a past president of the European IASP chapter, who's done magnificent work to support this guideline. But we will share it also through our Pain in Motion social media soon. But we're still in contact with the Belgian government, who is responsible for the Belgium guideline, for the new Belgium guideline for chronic pain management. And we're still discussing with them what will be the best strategy for spreading it in also potentially internationally, because of course, obviously, it has potential value for other countries besides Belgium too, because it's based on the international evidence.
Estaba comentando que si esa guía clínica está en inglés disponible, me dice que por ahora está disponible en francés y en Dutch, que son los idiomas que se hablan en los Países Bajos y también en Bélgica, y en realidad esto lo están trabajando en conjunto con otros médicos de otros países, e incluso tienen un acercamiento con el gobierno allá, así que quieren saber qué idioma utilizar y con el equipo de Pain in Motion trabajar en traducir estos documentos para que sea, ojalá de acceso universal finalmente, esta información, porque saben que puede beneficiar a muchas otras personas. Así que vamos a estar atentos. Well, we have to check that maybe in a few weeks or months. I was reading something in Spanish because a lot of these guys obviously speak English, but not everyone in my country, Spanish speaking is the majority. So I would like to recommend and I would like to know what your opinions are in relation to this book where you contributed to a chapter. It's related to manual therapy in the pain management, but I don't know if you recognize the front.
It's from our dear colleagues from Madrid.
Yep, it's from Spain, from Andrés
Yep.
Quevedo, Alexandra Alonso, Jose
Yep.
Luis Alonso. And it
Yep.
has a lot of concepts related to pain neuroscience education and different phenotyping, and it's in Spanish. So I would say
Yep.
that I would recommend it. What would you say?
Well, sure, I can recommend it. The fact that I contributed is a bit of a stretch. Also, I asked to remove my name for any next edition of the book, not because I don't like the book. On the contrary, I do like the book very much. So again, I would strongly recommend it, but I haven't really contributed to it. The reason why my name was mentioned in the book is because we have been teaching at their university in Madrid for years in their manual therapy program, their master program in manual therapy. We gave there the module on chronic pain management for years now, and that has been a long-term, really fun and efficient collaboration. And this way, we also brought in the knowledge of pain science into their program. And of course, many of the colleagues of the team of Madrid University then picked up that knowledge and also contributed this way in that book. But it's not that it was me writing it, and it's not that they translated stuff that I wrote, because I didn't wrote a single word. And that's also why I asked them to remove my name, because I hadn't seen the book before it was published, and then it was already published with my name in it, which shouldn't have happened, obviously, but it was out of my control.
Wow. And it was a surprise for me because as I thought that, I saw your name and said, "Oh my God, Joe contributed here. I'm going to buy this book."
Well, I still recommend to buy it, but not because I'm part of it. On the contrary, I wasn't part of it.
Bueno, estaba preguntando si es que tiene alguna recomendación de literatura en español, que muchos de los que estamos acá, por supuesto que hablan inglés o lo entienden al menos también, pero en español la mayoría entendemos más o leemos y aprendemos así. Y yo estaba mostrando este libro de terapia manual ortopédica en el tratamiento del dolor, que es relativamente nuevo. Y hay un capítulo que habla de educación y neurociencia del dolor, donde aparece Joe como un contribuyente ahí. Pero él está clarificando que pidió que no aparezca su nombre en las nuevas ediciones porque él no escribió ni una sola palabra del contenido de ese texto, aunque hay figuras respecto a los algoritmos que él planteó hace mucho tiempo, hay referencias que hacen obviamente alusión a su investigación. Yo diría que está bastante basado en neurociencia y evidencia lo que están planteando los colegas ahí, a pesar de que sea un libro de terapia manual, el capítulo en el que está este contenido es bastante robusto, así que una forma de comenzar puede ser empezar a leer algunas cosas ahí de todas maneras. Okay, and now, as an advice for professionals, Joe, how can clinicians effectively manage the expectations of patients seeking quickly or quick solutions for complex problems?
That's a nice one. And again, this is a very significant problem because for sure that's within your question that I like very much. There's already the strong message that you should thoroughly assess, examine, question the patient's expectations for care, not so much only in terms of expected outcomes, in terms of time, but also in terms of what kind of treatment do they expect from you as a physio, because patients can have strange expectations. One thing to manage is to become aware of it, that we can influence it in many different ways, and that starts when they approach the website of your clinic, of your practice. The information that you present there is already influencing the patient's expectations for care. What kind of stuff they can read or see on the walls when they are in the waiting room of your clinic. So you have multiple ways of influencing the treatment expectations in a positive way, of course, obviously, before you even get to talk with your patient during the first session, during the intake. But even then, of course, if you influence the expectations of your patients in a positive way, in line with the type of treatment that you are willing to provide to your patients in your clinic or in your practice, even then, of course, there can be a clear mismatch between what you want to provide or what you consider appropriate and evidence-based to improve the health situation of your patient versus what they want and what they expect. But then, of course, it's your job to sit down and take time with your patient to discuss this, and that's what shared decision making is all about, and that should be part of the preparatory phase before you actually start treating your patients, that you try to align with your patients what kind of treatment they are keen to have. And it's not simply us deciding what the treatment will be. No, it's aligning with them, and that's what shared decision making is all about. And if you're not commonly using it, I strongly recommend to start doing this, because it's also a lot of fun, and it boosts your therapeutic alliance substantially, and that's a key predictor of a good treatment outcome.
Él estaba preguntando que cómo se pueden manejar entonces efectivamente las expectativas de los pacientes que están buscando a veces soluciones rápidas para problemas que son muy complejos. Y me dice que le gusta mucho esta pregunta porque inclusive ya en la pregunta estamos considerando algo que antes no considerábamos, que es las expectativas de la persona. Entonces que tienes que tratar de alinearte con el paciente, implementando sí o sí la toma de decisiones compartidas, porque sabemos que eso puede hacer que la alianza terapéutica se vuelva más robusta y que eso puede ser un predictor de éxito en el tratamiento. Ahora, también es importante entender que cuando le pregunto las expectativas, preste atención, porque dependiendo de cómo la persona te buscó en Instagram, en internet, en la página de tu clínica, o lo que ha leído de ti, lo que ha buscado, investigado en diferentes partes de ti como terapeuta, ya va a estar influenciando sus expectativas. Entonces es importante que haya algún grado de coherencia o conexión, y por eso, primero que todo, tienes que considerar preguntarles, porque los pacientes a veces tienen algún tipo de expectativas que pueden ser medias extrañas. I would say that this has changed in my practice a lot, Joe, because I've been asking for their expectations for almost 4 years or 5 years now, I would say, and sometimes the expectation is not to ease the pain, is to learn something. I want to learn which exercise should I be doing, or what else can I do to sleep better, or how can I understand this because no one has been able to explain me, and I would say, that sounds like achievable.
Yeah, exactly. So that's magnificent. A total new way of working with patients arises at the horizon as soon as you start questioning their expectations for care, and that nicely fuels also the content of the shared decision making too.
Le estoy comentando yo que, de hecho, desde que yo evalúo la expectativa directamente en una encuesta de ingreso, o el día uno en la entrevista incluso, que eso han pasado probablemente 4 o 5 años de que lo estoy implementando, y que a mí me ha influenciado mucho la manera de actuar, porque una vez que le pregunta, así como decía Joe, que a veces te encuentras con expectativas entre comillas extrañas, a veces aterrizan bastante el proceso los propios pacientes, porque yo sé que estoy en un escenario diferente, ahora hablo como yo, particularmente como kinesiólogo, porque la gente que me viene a ver a mí, como decía Joe, ya ha averiguado de qué es lo que voy a hacer yo, o cuando entran a la consulta aquí no hay modelos anatómicos, ven un cuadro de un cerebro, ven libros de dolor, como que empiezan a notar que aquí es otro el mensaje, y a veces la gente me pregunta y me dicen la expectativa, me responden que quieren saber cómo manejar esto de mejor manera. La expectativa no siempre es que se me elimine el dolor o que desaparezca. Muchas veces sí, pero no es siempre. Entonces, hay muchas otras oportunidades donde la persona te dice, quiero saber cómo poder mejorar mi higiene del sueño, quisiera saber cómo entender esto porque nadie me lo ha explicado de una forma en la que lo entienda. Y yo le digo que eso suena como que se puede alcanzar, no es algo inalcanzable. A diferencia de cuando alguien te está colocando ahí en la expectativa de que quiere que se elimine para siempre el dolor de su vida, y tú ves que el diagrama está pintado completo, es muy difícil garantizar algo así. Amazing.
And can I perhaps add a bit to that, Nico?
Absolutely. Please.
For those unfamiliar with the concept of shared decision making, it's try to, if you want to try it, it's not difficult at all, and it's a lot of fun, again, because you emphasize the therapeutic alliance with your patients. No matter what the outcome is, you always emphasize and strengthen your therapeutic alliance with your patients, and therefore it's good to have a real structured approach to do this. And the structure that I typically use for doing the shared decision making is, first you offer them two options. And one of those options for sure should be very much in line with the type of treatment that they are expecting. And the other option is then the option that you think consider the best option to treat them. And then the patient has two options to choose from, but of course, before they can make the decision themselves, because it's always the patient in the end who makes the decision. And even if they still then use the option that you don't like that much, then you still go with their choice, of course. But before they make the decision, they also need to be informed about the anticipated outcome. And that's where you also provide evidence-based information. And if they want the quick fix, then you can nicely explain, well, I'm happy to give you the quick fix. I'm trained as a manual therapist. I can do the quick fix, but the quick fix will not fix much, except for very short-term anticipated pain relief. That's the best you can get. But if you ask me, because the patient, for instance, wants to be able to get back to their full-time job, or they want to get back to be able to do cycling or whatever they want to get back to, their functional goals are key to, of course, to consider. They won't be able to do that with the quick fix treatment. So for that, they will need the more comprehensive multimodal approach. And then if they get that type of information, then they can make the decision. So this three-step structured approach of first asking them, first providing two options to choose from, explaining the content and the anticipated outcome of both options, and then allowing them in the final step to choose. That's a structured approach to shared decision making that can be implemented in clinical practice.
Excellent, thank you for that. I will translate now. Dice que quería agregar un par de cosas para la implementación, porque quizás no todos están familiarizados con tomar decisiones compartidas con los pacientes y de lo que se trata es de ofrecerles siempre al menos dos opciones, una que esté en sintonía con la medicina basada en la evidencia y la otra muchas veces que esté en sintonía con lo que la propia persona quiere o cree, pero que tienes que entregar información antes de que tomen la decisión, tiene que haber información clara respecto a lo que dice la evidencia científica y que si una persona, por ejemplo, dentro de esas dos cosas en la balanza, quiere el arreglo rápido, la manipulación, el alivio inmediato, bueno, quizás estás entrenado tú como terapeuta físico para hacer algún tipo de intervención manual o manipulación o masoterapia o lo que sea que tengas en tu arsenal, pero que le puede entregar algún grado de alivio temporal y se lo vas a explicar de esa manera. Puedo hacer esto, va a ser a corto plazo, probablemente no va a ser la solución definitiva, porque si lo que quieres tú es volver a tu trabajo de tiempo completo y recuperar tu vida, en realidad esto otro que estamos haciendo, en realidad o que podríamos hacer es lo que puede mejorar la posibilidad de que así sea. Y no tenemos que necesariamente influenciar nosotros la decisión porque finalmente la va a tomar el paciente y tenemos que respetarla. Si el paciente quiere esa manipulación o ese alivio temporal, entonces lo vamos a hacer igual, pero que sea informado. And also, Sebastian in the chat add to the expectation question before that maybe the patient is asking that they want to know if if it is something dangerous because it has been lasting for a long time. And we know that the majority of cases is not dangerous when we assess
True.
them.
Exactly, and then reassurance is a very important aspect of pain education, for instance. That's one of the main outcomes, of course, of pain education, that you reassure the patient. But not only during the pain education, I would say during the complete treatment, it's always an important aspect. And in that respect, of course, there is increasing evidence from population-based studies that chronic pain, especially chronic widespread pain, is also associated with decreased life expectancy. But that's something I never, of course, share with my patients, and especially not because much of the decreased life expectancy of people with chronic pain is actually due to a unhealthy lifestyle. So if you target those relevant lifestyle factors in individual patients, I don't consider them to have a decreased life expectancy. So then people are not dying from chronic pain in general, I would say. I think that's still a conclusion that can be made with the available evidence from those population-based studies. But chronic pain also actually is strongly linked to an unhealthy lifestyle, and that's why it's so important that they should improve their lifestyle.
También dice Joe, para agregar un poquito más de información, que bueno, en esto de la toma de decisiones, de informar bien a la gente, la importancia de abordar los pilares relacionados al estilo de vida, que son cosas que se pueden modificar muchas veces, pero que es más difícil de cambiar. Sabemos que las personas con dolor crónico tienen menores expectativas de vida, pero que ese es un dato que él no comparte con los pacientes, porque no es que la gente necesariamente esté muriendo de dolor crónico, sino que más bien son esos factores del estilo de vida los que podrían generar este desenlace porque hay muchísimas comorbilidades y hábitos que no se han modificado. Así que tenemos mucho en qué podemos intervenir sin duda. It's been amazing, Joe. And I want to ask you something. Are you willing or planning to come back to Chile sometime?
Well, we've been in Chile twice to give courses. It was a really spectacular experience for me to be able to teach to clinicians in Chile, and also to enjoy the fantastic country, the fantastic food and wine. So I really enjoyed it. I don't think we have anything very concretely planned right now in Chile, but for sure something will pop up in the future, and I will be more than delighted to return to your fantastic country with so many kind people living there. And what I've seen from Chile is only, of course, a slight part of the country, but what I've seen is very beautiful. So I'm a big fan of your country.
So if we invite you, you might consider it.
Sure, absolutely.
Because I know that you, well, I was in your course last time in Viña del Mar, and I know the guys from Movement Solutions as well, so we might organize something because I'm the current president of the Musculoskeletal Physiotherapists Association. It's a non-profit organization, but we are doing an annual congress live next year. We might check the dates and invite you to give a course and also to participate in the congress. That would be very nice, Joe.
Sounds good. Happy to explore it further.
Excellent. Well, it's been amazing. Thank you for your time. And now I'm going to ask the audience to turn on their camera so we can take a little picture then. Let's see. Prendan sus cámaras si es posible para que saquemos una foto y ahí vamos a dar palabras para el cierre nada más. Let's see. So we are sharing these on social media, but then I'm going to upload the video, Joe, in YouTube, I would say, and I'm going to send you the link as well if you want to share it, because
Sure.
the Spanish-speaking audience might be...
Yeah, excellent. And we can share it through our Pain in Motion social media too.
Yeah, I already tagged Pain in Motion and your account on Instagram, so we're going to share this. Y a todos los que están ahí, compartan esta foto, compartan el contenido, después lo voy a subir al canal de YouTube, así que ha sido una jornada enriquecedora sin duda, un ratito de conversación con el gran Joe. And I hope I hope really to see you soon live. Maybe I'm going to Europe, I don't know. If not, we will be waiting for you in Chile next year, maybe. I'm going to write you an email, Joe.
Excellent. Have a nice day in Chile, everyone.
You too. Have a nice one. And thank you again.
Bye, everyone.